Hi, I'm Dr. D. Madhu, Senior Consultant Surgical Oncologist and Robotic Surgeon from KIMS Hospital. Today we are going to discuss about bladder cancer, how it occurs, what are all the different symptoms of bladder cancer, and how to investigate and what are all the treatment modalities available for bladder cancer. And why we are discussing about bladder cancer today is this month is Bladder Cancer Awareness Month, May. So this is considered as a Bladder Cancer Awareness Month. We are going to discuss about bladder cancer. The cancer that occurs in urinary bladder is called bladder cancer. The incidence of bladder cancer in the society compared to other cancers is low. But in the recent past, the incidence of bladder cancer is increasing. What could be the reason for this increase in the incidence of bladder cancer in the society? This could be due to the rampant increase in the smoking section of the society. Many people are becoming smokers, especially the youngsters, and the habit going on for a long period is known to cause bladder cancer. In certain patients, it can occur as an occupational hazard, like a chimney sweepers, they'll be exposed to more heat, and certain people working in crop fields with usage of pesticides, this exposure is known to cause bladder cancer. These are some of the factors which are known to cause bladder cancer. Some other factors like chronic stone present in the bladder, stone being present in the bladder for a long period, and chronic worm infestations. Certain worm infestations are known to cause bladder cancer. These are different scenarios where we can notice bladder cancer in certain patients. And family history is very rare in the case of bladder cancer. So most of the patients, they acquire the disease because of some etiological factor, or sometimes there may not be etiological factor. But the familial incidence is almost nil with the bladder cancer. How these patients present to the clinician, what are all their symptoms, in what way they come to the doctor. Most of the times they present with blood in the urine. It is called hematuria. Sometimes they may present with pus cells in the urine, but these are varied presentations. Most of the times, at the end of the maturation process, when the person is passing urine, when it comes to the end, at that time, if you notice some blood in the urine, we have to suspect the source from the bladder. This is called hematuria, terminal hematuria. So in these situations, there will be natural anxiety for the patients. They go through a lot of mental trauma, and they have to approach immediately the clinician, either it should be a urologist or it should be a surgical oncologist. Once they approach, the urine sample will be taken and it will be sent for the malignant cells cytology, and it will be sent for culture sensitivity, and some baseline cystoscopy is done. This cystoscope is a small endoscope that is passed into the bladder through the urethra, and the entire surface of the bladder, the urethral openings, the base of the bladder, dome of the bladder, every surface of the bladder is being inspected with the help of the cystoscope. So Once the cystoscopic evaluation done and the urine for cytology is positive for malignant cells, and suppose if we see a growth in the cystoscopy in the bladder wall, the urologist or surgical oncologist should take a biopsy from the lesion to prove the disease, that it is so and so cancer. Suppose if it is resectable completely, transurethral bladder tumor resection can be done. And suppose if it is a single lesion, if it is multiple lesions, or redness in the bladder found, there are different kinds of findings. According to the situation, we have to manage the patient. This is the preliminary evaluation of a patient with bladder cancer. Once this preliminary evaluation is done and we have the biopsy proof, then the next step in the management is complete evaluation, that is imaging. There are different kinds of imaging like a contrast CT, MRI and PET scan. Of all the three, we would like to prefer MRI scan. Why? Because you will have more characterization, delineation of the wall of the bladder, and exact characterization of the extent of the lesion. All these things can be done. So once the imaging is done, and if the biopsy shows the lesion is very superficial, you can try one more transurethral resection to get the negative margin. Suppose if the lesion is little bit bulky, if the tumor in the bladder is little bit bulky, you may be seeing the muscle fibers also in the biopsy specimen. In such situations, the patient may have to undergo surgical resection. So this is the problem for the patient, because the bladder has to be removed. Suppose if the bladder has to be removed, then what is the alternative? The patient will go into anxiety. What has to be done? What will be my natural way of life? All these things are different anxious factors in the patient's mind. It is the job of the consultant or a clinician who needs to counsel the patient that there will be two types of bladder diversion, urinary diversions, like the ideal conduit, where the urinary diversion will be done so that the urine will be coming from this side, or there is orthotopic neobladder, where the patient will have natural urine passage. That means we resect the bladder and we utilize the small intestine to prepare a bladder, and that bladder will be anastomosed. That is called orthotopic neobladder. That will be sutured to the urethra again. So these are different scenarios for the surgical management of bladder cancer. Once the treatment line is decided, the patient has to undergo further preparation for surgery. This is the line which I am taking to the side of the surgical treatment site. Certain patients, they don't want to have this surgery. They want organ conservation protocol. Organ conservation protocol means they want to retain the bladder. Such patients who may not tolerate the surgical stress, who have multiple comorbidities, who are not willing for primary surgery, can be offered the non-surgical treatment that is called chemoradiation. This chemoradiation treatment, sometimes it's given over a period of time, for example 2 months, let us assume 2 to 4 months. In this period, there is chance that the tumor in the bladder may respond to the chemoradiation and it will shrink by itself. Suppose after the chemoradiation, if we again reevaluate the patient, and do a cystoscopy and do imaging, everything, and if we find a residual tumor in the bladder, then it is always better to go for surgery. That is radical cystectomy. That is the bladder removal. So this is the other arm. So the surgical arm and the conservation protocol arm. In the case of conservation protocol, we try to preserve the bladder by giving non-surgical treatments, and after non-surgical treatment, if the tumor responds completely, the patient can be placed under follow-up. Suppose if the tumor doesn't respond completely and residual disease is there, the patient should undergo surgery. Now let us come to the surgical arm again. In this surgical arm, patients who are fit to undergo surgery, before undergoing surgery, they should be prepared adequately. They need mental preparation. They should be explained where we are going to place the urethrostoma, urinary stoma, or the orthotopic neobladder, wherein they won't have any stoma and they will be passing the urine through natural urethral orifice. These things should be counseled before surgery to alleviate the anxiety that is there in their minds. Once this is done, the investigations that are required for surgery will be done and the patient will be taken for surgery. This surgery that is done for urinary bladder is called radical cystectomy. Radical cystectomy. So in which the bladder is removed along with the prostate gland. Bladder is removed along with the prostate gland.